Sourav Santra to give the first talk on Beyond the Surface, Approach to Internal Limiting Membrane Peeling Surgery.
Hello, good morning everyone. So today my topic is Beyond the Surface, Approach to ILM Peeling Surgery. So what are the indications of ILM peeling? Full thickness macular hole, VMT with or without ERM, optic disc maculopathy, myopic foveositis, sub-ILM hemorrhage, and non-resolving macular edema. This is the international classification of macular hole. So stage 2 and beyond we do pars plana vitrectomy. Stage 1 we observe. So what is macular hole? It's a full thickness defect in the foveal center. Prevalence is 4 out of 1000, mostly above 63 years of age, more prevalent in females. Incidence in the fellow eye is 5 to 16%. On slit lamp, we see a round excavation with well-defined borders interrupting brim of slit lamp, and overlying semi-translucent tissue, which we call the pseudo-operculum, and associated with cuff of subretinal fluid. Clinical features: vision depends upon size, location, and stage of the macular hole. Patients generally complain of difficulty in near vision and metamorphopsia. In advanced stages, there is scotoma and micropsia. Management: stage 1 holes with good visual acuity are observed. Stage 2 and above macular holes, we do a pars plana vitrectomy with or without ILM peeling, depending on the size of the macular hole and the internal tamponade. So macular hole cover is done with, most commonly is done with inverted ILM peeling or multi-layered. Sometimes lens capsule, amniotic membrane, or retinal graft can also be used to cover the hole. Internal tamponade depends upon the size of the macular hole. Sometimes we can use silicone oil too. Prone position depends upon the tamponade. It may last for 3 days to 3 weeks. So this is a normal full thickness macular hole surgery. Next, I'll be sharing some of different case scenarios with full thickness macular hole. So this was a case of high myope patient with full thickness macular hole, but with ERM. So first we have to peel the ERM, otherwise we can't peel the ILM. So ERM was removed, and it was a large hole with, and the patient was high myopic. So next was a case of traumatic full thickness macular hole. In such patients, mostly the PVD induction is very important in this younger age group. Otherwise, ILM peeling is mostly easy to do, but the PVD induction is the difficult part in such young cases. Next is a RD with full thickness macular hole. In this case, some surgeons prefer doing a ILM peeling in such cases without PFCL, but I prefer doing ILM peeling under PFCL. It helps to, it gives us support. So this is the pre-op OCT image and this is the post-op image. The retina is settled with closed macular hole. This was a case done elsewhere. Patient came to me with recurrent inferior RD with full thickness macular hole, and a subretinal band was traversing through the hole. So we have to remove all the tractions to secure to close the macular hole and to settle the retina. So at first I did a ILM peeling under the PFCL. It was a large macular hole, is mostly tractional. Then I removed the subretinal band, and you have to remove all the tractions in these cases. There was a ERM near the inferior arcade also, so you have to remove it also, otherwise the retina won't get settled. So this was the pre-op OCT image and this is the post-op image. So basically my take-home points for better visibility of the ILM, there is no harm in staining multiple times. You have to remove all the membranes on traction that are associated with the macular hole. It's better to create the initial edge of ILM edge. It's better to do it inferiorly. An area of the ILM peeling depends on the size of the macular hole. In high myopes, to reach the ILM, posterior sclerotomy can also be done, and entering the eye without the cannula, you can do that also. In RD with full thickness macular hole, better to do ILM peeling under PFCL. Prone positioning is crucial post-surgery. You have to explain it. There is a prolonged recovery time and patient needs to be counseled properly. Thank you.
Very nicely performed surgeries.
Thank you, ma'am.
Yeah.